Since the dawn of humanity, one thing seems to persist in all human societies: social stratification. In all political systems, in all parts of the world, some humans always seem to acquire more resources, more power, more fame, and more connections than the others. We may all be created equal at birth, but we certainly do not have equal chances to survive and to thrive in life. This is the difference between inequality and inequity. The problem is not the existence of social stratification or inequality, but that it nearly always arises from gross injustice or inequity. Those at the bottom of the social pyramid have to struggle much harder to go through life. They also tend to be less healthy and live considerably shorter lives. Whenever this inequality within the society becomes extreme, with only a few exceptionally wealthy at the top and a broad, poor, miserable base at the bottom, societies can become very unstable. Some think that our own inherent greed is to blame. Greed must have evolved as a very favorable trait in historic times. It would not be surprising if the greedy among us, who accumulated more resources for the rainy day, were also more likely to survive, because the rainy day would always come. But in the 21st century, do we still need greed? It's making our societies inequitable and unstable. At the turn of the millennium, 11 million preschool children were still dying in the world each year. Sadly enough, studying this problem revealed that social stratification persists even among those at the very bottom. An analysis by UNICEF, which was hoping to celebrate the global progress in child mortality reduction, came to an inconvenient conclusion. In far too many instances, the progress has been achieved at the expense of the least fortunate children. In 2/3 of the countries that made significant progress in reducing child mortality, their achievement increased the gap in the risk of death between the wealthiest and the poorest children. This was really counterintuitive. How could this possibly happen? It turns out that the wealthy capture new resources, technologies, and health interventions much more readily than the poorest. In many countries, the wealthy were the first to ensure that their children received any newly available vaccines, and also the best new antibiotics, and that any new health programs scheduled to be rolled out were rolled out in the cities and places where the wealthy live. The whole new area of so-called pro-poor research emerged from these unexpected findings. We need new ways of providing health care to the poor. We can't resort to the solutions that are presently unfeasible, such as building hospitals in places with no infrastructure to support them, or redeploying highly trained doctors and nurses. But just a drop of blood on a special device can provide information whether the child has malaria or not. This removed the need for a functional laboratory, full blood tests, the doctor and the nurse. Moreover, a properly trained community health worker can accurately diagnose malaria and provide a safe and adequate treatment, saving the lives of the most disadvantaged children. Pro-poor innovations reduce the cost of getting healthcare to the poorest, where many more lives can be saved in comparison to the wealthier areas. UNICEF's analysis showed that such innovations could justify the strategy of reaching for the poorest children first, which then becomes both an equitable and a cost-effective approach. Countries that have taken this path, such as Ethiopia, Rwanda, and even Nepal, have managed to achieve massive reductions in child mortality, and at the same time, they also reduced inequities in their societies. This resurgence of interest in identifying, measuring, and addressing inequities takes us back to the origins of modern global health. In 1978, global health leaders met in Alma-Ata in present-day Kazakhstan. With involvement of the WHO and UNICEF, they discussed a new way of improving health: primary health care. The meeting also assigned importance to community mobilization, safe water and sanitation, and improved nutrition for women and children. This conference seemed like a great step forward, but within a few years, and against all expectations, it had fallen into trouble. The 1980s has been a decade of economic downturn experienced across the world. This left many countries struggling to fulfill their promise of comprehensive primary health care. This sobering lesson from relatively recent history has important implications on us all as we undergo a transition from the Millennium Development Goals to the Sustainable Development Goals.
We should learn that local money and ownership matter. The countries that started to finance themselves were far more likely to sustain the gains made with initial international financing, even if they focused only on a limited number of health interventions. Also, enlightened leaders and communities are needed to promote highly cost-effective interventions that can reach every child in the society.
Those interventions should be viewed as an essential part of the rights of women and children. An Indian economist and philosopher, Amartya Sen, has received Nobel Prize in Economic Sciences for his contributions to welfare economics, economic and social justice, economic theories of famines, and indexes of the measure of well-being of citizens of poor countries. He and several other economists argued that a healthy start to life, with good nourishment, is one of the best investments for future economic growth of the country.
But the greatest successes were achieved in countries that paid attention to both delivering medical interventions and investing in so-called social determinants of health, such as improving access to clean water and sanitation.
Social determinants of health can be just as important in reducing deaths from many diseases of the poorest in the society as providing medical care is. But perhaps the most fundamental lesson from the last 40 years of global health has been that without the direct involvement and empowerment of the people themselves, all health gains are likely to only be temporary. A Bangladeshi social entrepreneur and economist, Muhammad Yunus, has pioneered the concept of microcredits that are given to people who had business ideas but who were too poor to qualify for traditional bank loans. In 2006, he was awarded the Nobel Peace Prize for his efforts to create economic and social development from below.
The challenges of improving the health of the so-called bottom billion people should be addressed soon to prevent inequalities to widen at an even faster pace. Not only are the richest 1% becoming richer than ever before, but they may soon have access to technologies and innovations that will pull them even further away from the rest of the humanity.